Hello, Mr. Wall. My name is Dr. Gianni. I'm the radiologist who's reading your MRI of the knee. I'm going to walk you through the findings in my report, and as I do that, I'm going to scroll through the images so that you can get a visual with what I'm describing. Before I go into each of the findings, I just want to say from the outset that there are several injuries on your exam that are not likely to heal properly on their own without the intervention of an orthopedist. So my recommendation is to make an appointment with an orthopedist. They are a specialist type of doctor who deals specifically with issues related to the joints, especially complex issues. And not only are they the best type of doctor to evaluate your knee in the clinic, if they decide that surgery is necessary in order to fix these injuries, they're also the doctor that can perform that surgery. So they're it's a one-stop shop. They're the best person to see, best person to give this report to. So the first thing that I noticed on your exam is that there is complete tear of the ACL. So the companion ligament to the ACL is this. This is the PCL. Just note its thickness, its level of darkness that goes through it. Imagine something similar should be right here, but this heterogeneous signal on the MRI is consistent with a complete tear. Next, I noticed that there is a mild amount of edema within the proximal fibers of one of your calf muscles called the soleus muscle. This is consistent with mild muscle strain. Next, I noticed that there is a tear of your lateral meniscus near the root. This type of tear is called a parrot beak tear. It just describes the shape of the tear. At the location of this tear, there is a flap that is extending away from the meniscus into the intercondylar notch. So a flap of the meniscus means that the tear has caused sort of like a sliver to form, and then that sliver has flipped into a location that it shouldn't be. So that is this bit of meniscus flipping into the intercondylar notch. This can occasionally cause people's joint to catch, like it's locking. It won't let you complete full range of motion, and it's something that an orthopedist will want to know about. Next, I noticed that there is another tear, this time of the medial meniscus. There are two menisci in the knee, by the way, one on the medial side and one on the lateral side. So this is the medial meniscus. Typically, when it's healthy and normal, it looks like a black triangle like this, but you can see this vertical tear running through the posterior portion of the meniscus. So the inner third here, it inserts normally at the posterior root, but the peripheral third tears completely. Let me show to you another way. So this is the inner third of the meniscus that reaches the root the way it's supposed to, but then, and this white part is the tear, but the posterior part does not make it all the way. So this is a tear of the peripheral half, essentially, of the posterior root of the medial meniscus. I know it's a mouthful, but I hope showing it to you with pictures helps you to understand. Next, I noticed that there is a moderate bone contusion at the posterior aspect of the lateral tibial plateau. So this is consistent with transient dislocation of your knee at the time of your injury. So the ACL typically runs from here to here, and it's usually tight. It's a principal stabilizing ligament of the knee, and it's typically tight. When it tears, it allows your distal femur here to jump back where it can impact the posterior portion of the tibial plateau, seen here. This is consistent with a moderate bone contusion, and then I also see that there is a tiny microfracture. So this line of low signal here is consistent with a microfracture. It's essentially just a crack in the bone. So not enough to break a bone into two pieces, but enough to cause a crack. There's also a mild bone contusion at the weight-bearing portion of the medial femoral condyle, seen here, but it's less significant than the one that I pointed out to you a moment ago. Next, I noticed that there are several partial thickness fissures of the median patellar ridge cartilage and the lateral patellar facet cartilage. These do not exhibit any underlying bone edema, and thus they could be current. It's possible that these could be the results of recent injury, but cartilage takes a long time to heal. Sometimes it doesn't heal at all, and so fissures that don't have any bone edema may have been around for some time. It's possible they might not be related to this recent injury at all. I see people who come in for unrelated injuries, and they might have a cartilage fissure that they had from back in their younger years when they used to play sports. So not necessarily something that happened recently. Next, I noticed that there is mild edema within the inferior aspect of the prefemoral fat pad. So the knee has several different pads of fat within it that act like cushions inside the knee. This is the femur. The fat pad in front of it is called the prefemoral fat pad. This elevated signal within the inferior portion of it is consistent with edema, and this can happen in the setting of trauma because during moments of trauma, it can cause the kneecap to pinch the pad of fat against the femur. So a common post-traumatic finding. So if you're experiencing pain underneath the patella, it's likely related to this. Next, I noticed that you have a variant of anatomy within your knee unrelated to your recent injury. It's called patella alta. It means that the kneecap is higher in position than it typically is in the majority of the population. People with a patella alta are more likely to result in fat pad impingement like this, and they also have a mild predisposition to dislocating their patella. There are several other variants of anatomy which can also predispose to patellar dislocation, including a flat trochlear groove, which you do not have, or a lateral insertion of the patellar tendon, which you also do not have. So this represents a mild increased likelihood of a patellar dislocation, but you do not have any of the other variants of anatomy that often will cause that to occur. The last finding on the exam is a moderate knee effusion. An effusion is a buildup of excess fluid within the knee joint. Effusions form as a reaction to injury rather than an injury in and of themselves. They're a natural defense mechanism of your body, and anytime you injure anything internal to the knee joint, like the several things that I've pointed out so far, an effusion often comes as a natural secondary finding. You experience an effusion as a swelling sensation within the knee. So that brings me to the end of your exam. The remaining structures that I have not mentioned are intact and normal. The remaining ligaments and tendons are normal. The rest of the muscles are normal. But again, a complete tear of the ACL and multiple tears of the menisci are something that deserve the attention of the orthopedist, and they can decide if surgery is necessary in order for them to heal properly. So that brings me to the end of your exam. Again, my name is Dr. 𝘾𝙤𝙖𝙘𝙝. Thank you for choosing Look MRI. Please consider us in the future if you require follow-up imaging, and have a good afternoon. Bye-bye.